Man, otherwise I'll put this off because volume otherwise will two volume should not be on. Otherwise, come here.
Doctors, we are live, doctor. We can start the session.
Okay.
After successfully conducting themed retina meetings for the last 5 years, we present Fibrosis 2025. In 2021, the theme was angiogenesis. In 2023, we focused on atrophy, and now we're exploring fibrosis. A very warm welcome to all attendees of the Fibrosis 2025 meeting.
You are muted. Dr. Jayaprakash.
Good evening, everyone. Good evening, everyone. I would like to welcome you all to this today's segment of fibrosis. Today's flavor is on diabetic retinopathy, uveitis, and CSCR. I would request Dr. Raman to take up.
Good evening, one and all. So, for the first talk of the day, I would like to welcome Dr. Amani Fauzi. She is a vitreoretinal surgeon and a clinician scientist, professor at Northwestern University, where she divides her time between her surgical practice and NIH-funded research. She is recognized for her imaging research, and she was elected to the American Society of Clinical Investigations. And she has also received the Honor Award for the American Society of Retina Specialists, the Young Investigator Award of the Macula Society, the Secretariat and Senior Achievement Awards of the American Academy of Ophthalmology, and is a Gold Fellow of the ARU. So I welcome Dr. Amni Fauzi to present on the topic fibrosis in proliferative diabetic retinopathy, insights into cellular origins and mechanisms. Over to you, madam.
Good afternoon. I'd like to thank the organizers of the meeting, Dr. Raman, and my friend Dr. Bindi for inviting me to give this talk. I thought this was a very exciting concept of bringing basic or translational science and clinicians in the same room, and I was really excited to participate. So I look forward to the discussion after the talk. And so my talk is about proliferative diabetic retinopathy and fibrovascular membranes. And so we've been working on this for a while now and sort of trying to identify the cellular drivers of fibrosis and perhaps identifying therapeutic targets for these drivers. And I'll tell you a little bit more about that. And so we all know that diabetes can end up with advanced fibrosis. And unfortunately, even in the United States, we still see this presentation as the first presentation of patients to us with extensive fibrosis, traction attachments, hemorrhage, and all these membranes growing over the retina. And, I've always thought that there could be a way to prevent these from happening. And so that was sort of the excitement for this research. So we started out sort of asking a simple question. We've all sort of heard about this crunch phenomenon, and I think Professor Schlingemann will be talking about that. And so we wanted to see if we could figure out how bevacizumab enhances this fibrotic reaction in the membrane. So our first project was basically taking these membranes from sort of surgical membranes and preserving them, taking them out of the eye, and we used part of them for immunohistochemistry, and the other part we actually digested. So we had a group of patients who were receiving anti-VEGF preoperatively, and another group who did not receive anti-VEGF. So we isolated the membranes and then we digested them. So when you digest them, you basically break down the cell membrane and you just have floating RNA and proteins. And then to try to understand what the endothelial cells are doing in this jungle of sort of cellular compartments, we enriched the endothelial cells. So we used magnetic beads labeled with antibodies that recognize surface antigens on the endothelial cells. We purified the endothelial cells and sort of made endothelial cell juice, if you will. And then everything that's left over that's not endothelial cells, we analyzed it separately. So we basically separated the entire membrane into two compartments, endothelial cell and non-endothelial cell compartment. And as you can see, the groups were well balanced in terms of diabetes, duration, age, and such. So there wasn't really a bias in either group. And then we wanted to basically confirm that what we did what we thought we did. So first we wanted to make sure that we enriched the endothelial cells successfully. So when you look at the endothelial cell compartment versus non-endothelial compartment, whether it was the control untreated versus the bevacizumab treated eyes, we found that the markers of endothelial cells like VEGF receptor 1, FLT1, cadherin 5, the junctional component, and the like were more enriched in the endothelial compartment, whereas angiopoietin 1, which is usually expressed in the pericytes, and TGF-beta were not. So next, we wanted to look at what happens with bevacizumab when we compare now bevacizumab treated versus untreated, and we look at the endothelial cell compartment at the top versus the non-endothelial cell compartment at the bottom, and the bevacizumab treated are the white dots. So here we saw that, as we expected, when you inject bevacizumab, all the angiogenic markers drop down that we expect to go down. VEGF-A, VEGF receptor 1, and VEGF receptor 2, KDR, they all significantly downregulated. And we were surprised to see that angiopoietin 2 was also downregulated. We have a hypothesis in the paper. You're welcome to read that if you're curious. It was also downregulated with just bevacizumab. The other things that changed were upregulated. So cadherin 5, which is the junction, so the tight junction between the endothelial cells gets better with bevacizumab, which is sort of the anti-leakage effect of bevacizumab and anti-VEGF. And the other thing that went up was endothelin 1. And so we were interested in how endothelin 1 might be upregulated and causing fibrosis, and perhaps that's one of the ways that sort of fibrosis is triggered. But we were surprised that everything else we thought about as fibrosis drivers was not, and I'll show you that later. In the non-endothelial compartment, we also saw VEGF downregulation, and as you might know, VEGF is largely secreted from non-endothelial cells. So even though we saw downregulation in the endothelial cells, VEGF is largely driven by macrophages and other cells in the retina that secrete VEGF. So when we looked at the fibrosis markers, we were really puzzled because what we expected, as others have shown, is that CTGF would be up and TGF-beta would be up in the non-endothelial compartment, and we did not see that. The only thing that we saw different was downregulation of fibronectin, which we thought was consistent with the sort of anti-leakage effect. Large proteins don't escape from the blood vessels, and so there's a decrease in these fibronectins and other large cells, large proteins. So we can discuss later, and I'd be curious to hear what Dr. Schlingemann thinks, why this may be, that when you analyze the membranes, you don't see that fibrotic effect. And I think in my mind, the biggest answer would be that these markers of fibrosis are probably secreted from the retina. And so if you look in the vitreous, you see them, but if you look in the membrane itself, the membrane is such a tiny component, maybe not really a good way to see who's driving this fibrotic reaction. But yeah, I look forward to discussing this further. So I was discussing this project with one of our really spectacular scientists at Northwestern, Louisa Rispe, who's like a superstar in the vascular biology world. And I was telling her we were digesting the membrane and doing RNA and qPCR, and she said, but have you heard about single cell RNA? And that was my first sort of idea of looking at that. So here she said, if you just do single cell RNA, you'll be able to not only identify sort of the transcripts, but also link them to the individual cells in these membranes. So we don't have to make fibrosis juice. We can actually look at individual cells and query the RNA within each cell. So that was sort of the start of this project. We started this project around the pandemic, which turned into a logistical challenge, getting the membranes from the patients to the lab, but we managed to basically isolate these membranes. And so how this process works is my lab member came to the operating room. We harvested the membranes fresh, and then he ran to the lab, and basically instead of digesting, we dissociated the cells. So we just break down the bonds between the cells and generate a single cell sort of dissociated material. And that material is then driven very quickly to the lab, which at the time was in a different school. They had a better lab for single cell analysis at the University of Chicago. So you drove down to the University of Chicago, and there they basically process these cells very, very quickly. So that each cell is then wrapped into this gel, and then in each cell runs through the machine and is tagged with a specific barcode for cDNA. And so then you create these individual barcoded cells, and then each barcode is linked to a single cell. And so you can analyze the transcription factors from each cell individually. So instead of a membrane juice, we have individual cells and their sort of transcriptional components. And this project was really driven by a postdoc in the lab, Katya. And so when we started to just look at the big picture, what types of cells are in these membranes? So it turns out there's at least 4 or 5 types of cells. The first one is endothelial cells. When we look at the endothelial cells, we saw sort of what we expected, that angiogenesis is active. There's stalk cells, there's tip cells, there is immature and mature endothelial cells. And then when we look at the molecular profile, we saw tip cell sort of markers, ESM1, and we saw it when we did the immunohistochemistry in the tip cells of these endothelial cells in the membranes. We also saw VEGF-C ectopically expressed in the veins or the endothelial cells of the vasculature of these membranes, and that is also thought to be an ectopic expression which may drive escape from VEGF in some diseases, and maybe the driver for current trials that use VEGF-C in addition to anti-VEGF. The other thing we looked at in these membrane endothelial cells was the blood-retinal barrier, and we were not surprised to see that all the blood-retinal barrier components were expressed, but not in the sort of expected mature cells. There was sort of a haphazard expression, and some of them were not expressed at all. And interestingly, PLVAP, which is a marker of leaky endothelial cells and is normally only expressed in the choriocapillaris, was ectopically expressed in the endothelial cells, another marker of leakage. The next cells we looked at were the macrophages, and here we saw that there was a group of macrophages, a sort of a compartment that expresses all the cytokines, VEGF-A, VEGF-B, and that these are considered pro-angiogenic macrophages that sort of participate in this inflammatory neovascular compartment. So those were sort of the first sort of signals that we got from this. Angiogenesis is active. We weren't surprised, and then macrophages are participating in this angiogenic reaction. So next we wanted to look at fibrosis, as I said. So when we just look at collagen 1A and we look at which cells are expressing it, my original hypothesis was that endothelial cells are driving the fibrosis by transforming, so a process called endothelial mesenchymal transition. But we were surprised that the highest expression of collagen A was in the stromal cells and pericytes. So that drove us down a totally different path. As you can see, the endothelial cells are partly expressing it. So now we focus on the pericytes and the stromal cells. So as you can see, if we use the canonical markers, we find that there are sort of a range of stromal cells, starting from the vascular smooth muscle cells in the large vessels, and then pericytes in the capillaries, and we use canonical markers to identify them. And then the myofibroblasts are the sort of the big group of cells in that membrane. But we've really focused on this intermediate cell compartment, which express both pericyte markers and myofibroblastic markers, and we sort of named them transdifferentiating pericytes. So they're sort of in the process, and they've got this confused identity. When we look at the sort of cellular pathways that are activated in the normal pericyte, they're related to angiogenesis, developmental process. In a myofibroblast, it's geared towards fibrosis and development of extracellular markers. So you can really see the difference between those two. But these transdifferentiating pericytes appear to be confused cells that are doing both functions, fibrosis and vasculature. To further confirm that, we did something called trajectory inference analysis, which basically looks at the mathematical relationship between these cells. And it turns out that transdifferentiating pericytes form this intermediate node between one pathway that differentiate myofibroblasts and the other that has pericytes. So then we wanted to look at what makes these cells transdifferentiate and what drives this process. So we can look at sort of the gradient of expression of sort of transcripts in these cells. And we found this interesting sort of molecule ABP1, which seems to sort of have a gradient that goes up very high in myofibroblasts, very low in vascular smooth muscle cells. And we confirmed it by looking at immunohistochemistry of real membranes. And you could see here the white pericytes express this red ABP1, but also it's expressed outside the pericyte. So some cells that have the ABP1 in red don't have pericytes markers in white. And then there's other cells that are pure pericytes and don't express it. So we confirmed this gradient in a membrane in vitro. So what is ABP1? It was first described in aortic tissue, and this was the protein name ACLP, and it's got a signaling component and a carboxypeptidase component and a collagen binding component, putting it in the middle of this fibrosis. It's also associated with Ehlers-Danlos in mutations, and it's associated with a variety of fibrotic disorders, lung, liver, and adipose tissue. It acts in debated mechanisms, either directly on TGF-beta or indirectly. So what about the eye? Almost nothing was known about its activity in the eye. So we wanted to test hypothesis, but using parasites in culture. So we took human retinal parasites and cultured them and then exposed them to glucose and wanted to see if we can recapitulate this fibrotic reaction. Are parasites transforming to myofibroblasts in this sort of environment, and is ABP part of that process? So lo and behold, we saw that parasites really start to express collagen and other fibrosis markers as well as ABP when they're cultured in glucose, even for 24 hours, and it gets worse in 48 hours. Of course, TGF-beta was a bigger driver of all these components, but in red, glucose was statistically significant in driving this fibrosis. So in addition to being fibroblasts, converting to fibroblasts, these parasites also lost their natural parasite markers. So they're really changing their identity in this culture. So can we reverse this? So now we ask the question, can we use this ABP1 delivered in culture to reverse this by silencing ABP1? So we did that experiment. First, we confirmed that ABP silencer was active, and we saw that it lowers the amount of ABP transcripts and blunts the high glucose reaction in the cells. And when we used it to treat those cells, we saw that downregulation of all the fibrosis markers. So it seems that this reaction, the parasites leave the vessels and start to form fibroblasts. And this has been known in cancer biology and in other sort of organs, fibrosis, that once they leave the vasculature, they sort of transform into fibrotic cells. And this has been shown and may be conserved across organs. So this paper here described that this identity change happens in the brain and the heart similarly. And now we're adding the eye to that. So now we're basically confirmed that ABP1 may be driving this, and perhaps it could be a future therapeutic target to prevent fibrosis. And we're pursuing this now in a mouse model that we've created of fibrosis and ischemia. We basically want to catch these parasites in action by following them in a lineage tracing experiment and see if we can block it by blocking ABP1. And with that, I'll thank you for your attention, and I look forward to the discussion afterwards. And I'm very grateful to the invitation to speak to you today, and look forward to further discussions.
Thank you, ma'am, for the wonderful talk. We'll take the questions at the end of this session. I would like to invite the next speaker, Dr. Reena Schlingemann, who's a professor of ophthalmology, and he's a medical retina specialist in Amsterdam. His research interests include the role of growth factors in ocular angiogenesis and fibrosis, particularly in AMD and diabetic retinopathy. He is involved in several prospective clinical trials on the use of anti-angiogenic therapy in AMD and diabetic retinopathy. So I would like to welcome him for his talk on angiofibrotic switch in PDR. Over to you, sir.
Thank you very much. Thank you very much, Professor Aman, and your colleagues for this wonderful invitation. I'd like to discuss some old work from my group. It's slightly complementary to the previous amazing talk that we just heard, and it would be wonderful to have a discussion, yes, how the data sets align. I want to talk about the angiofibrotic switch in proliferative diabetic retinopathy. And I'm trying to advance here. Yeah. I'd like to start with this balance. We formulated in the past the concept of the angiofibrotic switch, which is basically something that we believe happens in all forms of wound healing, outside and inside the eye. because in most cases, wound healing starts with an angiogenic phase and transforms into a fibrotic phase. And our work suggests that the balance between VEGF as a driver of angiogenesis and a growth factor called connective tissue growth factor as a driver of fibrosis, the balance between these factors may be important in this angiofibrotic switch. I think the avascular eye is the eye has so many avascular tissues, and because of course the eye is a compromise between function and anatomy, and being constructed of live cells that need oxygen and nutrients that have to be brought in by blood vessels. But of course, the eye wouldn't function as a camera if all the tissues had blood vessels, so there's avascular tissues, and that makes the eye very vulnerable to situations where there's vascular insufficiency and a stimulus for revascularization, which often happens in a wound healing context. It appears that most tissues of the eye have a very robust wound healing response if the circumstances allow it. That may have also something to do with that evolutionarily the eye, of course, needs to be repaired very quickly if it's wounded, because otherwise you get an infection from which you could die. So ocular neovascularization happens in many areas of the eye, and we know it as ocular neovascularization. As clinicians, we see the growing blood vessels, and we tend to see it as a conditions of vascular growth. But I think these are all conditions basically of wound healing that have in itself the possibility to develop fibrosis, the very interesting subject of this conference. And of course, that happens in proliferative retinopathy, and where, of course, fibrosis, like the previous speaker also alluded to, is basically an end stage. And it's not only fibrosis, it's also the other elements of wound healing and scarring, contraction, and damage. This also happens in AMD. I think it's the subject of tomorrow, but also in AMD, I think the angiofibrotic switch occurs both under the retina, as you can see here in these choroidal folds, showing fibrosis in a subretinal neovascularization, as fibrosis of a type 1, a type 2 neovascularization here between the RPE and the neuroretina. And if you look at how these neovascular membranes under the retina, if you look at them and you compare them to granulation tissue, which is of course the typical wound healing tissue, there are many similarities in granulation tissue, which you see on the left side. There's basically a superficial layer of fibrin because of the extreme leakage of the growing and immature vessels, that you get fibrin deposition. There's a phase of capillary sprouting, there's a phase of maturation and pruning of vessels, and then there's a zone of fibrosis, vessel regression, and the scar formation. And that can, those phases we can also see in subretinal neovascularization. There's a dark rim around subretinal neovascularization, it's probably a fibrin layer. There's the front of capillary growth with highly leaky vessels which leak fibrinogen that can form fibrin. Then there's the maturation zone, and then there's, of course, eventually fibrosis and scar formation. And of course, that also happens in proliferative retinopathy. And we have coined this term angiofibrotic switch to describe this situation. It's not a black and white thing. It's not an on-off switch. But I think that in the tissue, in the process, this pro-angiogenic phase goes into a pro-fibrotic phase. So we've studied that, and of course we know that VEGF-A is the main driver of angiogenesis in all these conditions, and VEGF has several interesting effects. It's of course has a lot of effects on endothelial cells, but it also has a lot of other effects, and it also induces factors, for example, like connective tissue growth factor, and that is one of the factors that outside ophthalmology has been. Sorry, I want to go back. Back. Yeah, that has been research outside ophthalmology, connective tissue growth factor is known to be very important in fibrotic diseases, in normal fibrosis, in wound healing, and it's induced by TGF-beta, but also by many other factors, also by high glucose and ages in diabetes. And so it's an important central factor in the cytokines that are thought to drive fibrosis. It has several domains and thereby several interesting functions. It binds to VEGF, and it can also be induced by VEGF. So we studied CDGF in a knockout mouse, a heterozygous knockout, and we studied, because at the time when we started this research, CDGF was believed to be a pro-angiogenic factor in conditions in the eye with angiogenesis. So we studied the subretinal CNV wound healing model. I know it's not proliferative retinopathy, but I'll come to that. And basically, we did not really find a strong effect of the absence of one allele of CDGF in this model when we looked at the parameters of angiogenesis. So that didn't seem to be an important role in angiogenesis. But if we looked at CDGF levels in the vitreous of patients with not only proliferative retinopathy, but also other ocular disease like epiretinal membranes and other conditions, and we looked at these patients and we divided them into, we allocated degrees of neovascularization. So 0 was no neovascularization, 1 was active neovascularization, and 2 was active and inactive neovascularization. We found a clear, as expected, a clear relation with VEGF levels, but we didn't find a clear relation with CTGF levels, which you can see in the at the top one on the left. But if we looked at the fibrosis score that we gave to all these patients, we found a clear relation of CTGF with the fibrosis score. And more importantly, we found a negative relation with VEGF with degree of fibrosis. And if we looked at the ratio of CTGF over VEGF, we found a very strong relation between degree of fibrosis and this ratio. And that for us suggested that were of course associations, but they suggested that this angiogenic phase, which is driven by VEGF, which induces CTGF, which is known to induce CTGF, leads to production of CTGF, which which inhibits VEGF by itself, and therefore whereby this balance tips to CTGF and fibrosis starts taking the overhand in this wound healing response. So one would expect from this, if this is really true, and then one would expect that if you take VEGF out of the system, that you get more fibrosis. You would not necessarily expect to get more CTGF, and I think the data of Professor Fauzi didn't show an increase in CTGF gene expression, but that does not necessarily have to be the case because VEGF is one of the drivers of CTGF gene expression. But the CTGF that is already there in the context of fibrovascular membranes that are sensitive to CTGF in the absence of VEGF could make the process tip to fibrosis. And that is actually what we see, of course. We know from proliferative retinopathy that if we, sorry, this goes automatically. Let me go back. Yeah, no. There we are. We know from proliferative retinopathy that panretinal laser can induce a switch to fibrosis. And here's a case where a patient was treated with anti-VEGF, where you can also see that the angiogenic phase of proliferative retinopathy went into a fibrotic phase and more fibrosis after anti-VEGF. And that is the well-known, which is now called, we call that the angiofibrotic switch. It's also now called the crunch syndrome. It's a well-known observation that if you give anti-VEGF to a patient with proliferative retinopathy who has considerable fibrovascular membranes, there can be a very strong fibrotic response and scar response with contraction and retinal detachment. So it's now known that you should not do that too long before the operation. And I think there are also many patients that don't show this response, maybe because their fibrovascular membranes are not in the state where taking VEGF out of the system can lead to more fibrosis. It probably has to do with the state of the myofibroblasts. And that I was very interested from your single cell data, Professor Fawzi, whether your myofibroblasts actually have a CTGF gene expression, because I would expect those cells to be an important source. I don't know, but that would be a possibility. And it has also been shown in retinopathy of prematurity. There are some very sad case reports in the literature where young children were injected with VEGF, which led to a rapid angiofibrotic switch with huge fibrosis, contraction, and blindness. So is it all that simple? Is it just CTGF and VEGF? Well, probably not. Probably it's all protein networks that drive these processes. But I think our concept of an angiofibrotic switch and important roles for VEGF and CTGF may hold. We have reproduced the same data twice again after our first paper in different data sets. We've also looked at patients who were treated with anti-VEGF and shown that indeed CTGF, that the ratio, of course, went up because VEGF went down, but CTGF sort of stayed the same, very similar to your data. And future work should show the role of these other factors that are here in these complex protein networks. So to summarize, our findings suggest that CTGF is an important driver of fibrosis in human vitreoretinal disorders. The balance of CTGF and VEGF may be important in determining the transition from angiogenesis to fibrosis in situations like proliferative retinopathy, but probably also in neovascular AMD. Other factors that previously were linked to fibrosis may also have a role in angiogenesis, and these protein networks are probably the way to go to understand what is really going on. And CTGF may be a target for proliferative diabetic retinopathy and AMD in anti-fibrotic approaches. And this is our team that worked at the time on this data, which was some time ago, but it was an interesting concept to bring into the literature. I think other people have also reproduced it, so I'm looking forward to the great work of Professor Fawzi in the future also to sort this thing out really in detail. Thank you very much for your attention.
Thank you, sir. Thank you for the wonderful presentation. I would like to invite the panelists for today's discussion. I would like to invite Dr. Dinesh Talwar, who is an alumnus of All India Institute of Medical Sciences. He has edited 2 books, written more than 17 chapters in books, published more than 50 articles in international and national peer-reviewed journals, and presented in more than 150 national and international conferences. Welcome, sir. I would also like to welcome Dr. Karthika Palanisamy, who is a senior research scientist, who is an alumnus of Sankara Nethralaya, and she has done extensive research on the role of adiponectin-induced fibrosis in diabetic retinopathy. Welcome, ma'am. So, does anyone in the audience have any questions?
Well, I was curious about CTGF gene expression in the single cell analysis study.
Yeah, that's a great question. I don't remember off the top of my head, but we can go back and query the data again and look for it. I mean, I'm sure it's there because we found it in the qPCR, so I'm sure it's there. But my guess would be, like you said, in the myofibroblast, it's probably got a gradient as well, where it's almost non-expressed in the pericytes, but then goes really high up in the myofibroblast. So my question to you is, is CTGF too late? Intervening at the CTGF when the myofibroblasts already express it, is that maybe too late to intervene? And should we be going even further upstream in the process to try to prevent fibrosis? What are your thoughts on that?
Well, you may be right there. I don't know actually, but of course, our data have been out in the literature for quite a while. I know that pharmaceutical companies have worked on CDGF, but there has been no product has come out of that work. This may also has something to do with commercial reasons that they abandon these projects because it may be only a small market or something. I don't know. But it's also preclinical models are not easy or don't exist. So I think maybe that's the reason. But so maybe, yes, you're right. Maybe there were some serious investigations by pharma that were not published that that showed what you're saying. But and I think your work, I mean, that's the way to go. You have so much more data now with the single cell analysis to relate that to the vitreous protein levels and to come with a model of how fibrosis is induced is, I think, the way to go. And the protein that you identified would be very interesting for that.
Yeah, thank you. I think it's exciting to be working in this area, but also a little scary because now with all the Ozempics, the GLPs and all those drugs, I think diabetes control is getting much better. And that may be the biggest way to effect a change in this disease. And maybe we won't see fibrosis and diabetes anymore. So it's sort of
Hopefully.
I'm
Well,
wondering,
there will still be these odd patients that come around, even in countries where there's 100% coverage of screening, you still have patients coming for the first time with such end-stage proliferative disease. So just like you were saying.
Dr. Fauzi, when you see, basically, when you talked about individual cells in the membranes, but the basic pathogenesis is not going on in those membranes. Those are the end products of the whole process. The basic process is starting in the ischemic retina, which is the global retina. And basically what is happening is, like as you said yourself, that is the first thing is the hyperglycemia, and the second part of it is the advanced glycation end products, which cause the oxidative damage. And together they are leading to the initial pathophysiology. What you see at that end of the membranes is actually the end phase, which is you're just seeing what is now happening as a consequence of all those things being set into motion. What I could figure out, all these membranes finally seem to be working through TGF beta, actually. So if at all, like you said, it may be too late, but TGF beta may be the point where you can actually stop the inflammatory process from starting. And even before that, probably even before that, would actually be the tumor necrotic factor. Is the tumor necrotic factor which just starts the rest of the process. So I don't know whether there's work on treatment with tumor necrotic factor drugs for controlling the inflammation and preventing the stage of the fibrosis, because ultimately fibrosis is actually a healing process. Now what you're saying is, I don't want the healing process, which is effectively what you're doing with these with the tumor necrotic factor control. And that's why I wanted to ask, and related to that, there's something still missing, because there's a missing link why everyone doesn't develop the crunch phenomenon. Why should crunch phenomenon be there in just 5 to 10% of patients? It should be a universal phenomenon. So it also means it's something like somebody develops a keloid, most don't. So it's an exuberant response to healing, which gives us the fibrosis, which causes this kind of damage. So, I mean, what are your thoughts on that? I mean, because you've dealt with the later part of the thing, and Dr. Schlinger was talking about what actually is what concerns us clinically, the crunch finally. And I thought, after everything that I could analyze, I found that there's only one drug, one metabolite from or one cytokine from where the whole thing starts. And everything else then, it comes around roaming around in circles.
Yeah, I mean, I think you ask a very important question. I'll take number 2 question first, and that is, why do some people get crunch and some people don't? I think Professor Shingeman kind of touched upon that. If you high VEGF and low CGGF, and then you drop
I've lost you. You're not audible.
so I was trying to explain, if you have high VEGF in an eye and low CTGF, then you have just angiogenesis. If you drop the VEGF in that eye that starts with high VEGF, then you have the imbalance, and then CTGF takes over and you have the crunch. I think in some of the eyes that we operate on, the ischemia is not so bad. They've been lasered enough, they've been quiescent for a long time, and sort of the VEGF drive is not so high. So maybe those are the people that don't get that crunch phenomenon. It's just an imbalance, like he explained, which I found very fascinating. So if you start with low VEGF in an eye with kind of controlled ischemia, and then you give anti-VEGF, the anti-VEGF isn't really doing much, and so you don't see the crunch. That would be my sort of hypothesis.
But then that should happen universally when you bring down the VEGF. It doesn't happen.
I don't think
But
so. No, I think that it needs another factor. It needs
something else.
It needs the cells that can produce the fibrosis. So you need the myofibroblasts in the perfect state to be sensitive for that CTGF. And many patients won't either are not yet in that state, or they. So I think you because the fibrosis is not made by CTGF. CTGF induces cells to create fibrosis, and those cells are probably the myofibroblast or the transdifferentiated parasites. It's very interesting because already in the 70s, this idea of mural cells, parasites, becoming extramural and transdifferentiating into myofibroblasts was already published. I think it's great that you have now found data in the eye that happens too. So I think those cells need to be in the right state and of sufficient quantity to be able to create fibrosis in the presence of that CTGF in the absence of VEGF. I think that would fit most our hypothesis, data, whatever.
In continuation with that, Dr. Fauzi, I just wanted to ask you, have you evaluated the platelet-derived growth factor in those cells and seen whether the parasites which are transforming into myofibroblasts are those which have more of that?
We haven't
Because
looked.
that's one of the other factors which is supposed to be responsible for increasing the CGG, this factor, the connective tissue growth factor, and therefore maybe a part of that whole process.
Yeah, I'm happy to go back and look at PDGF and CTGF and confirm your hypotheses. But back to Professor Slingerman's idea, actually, to go back to that, so the cells, the membranes were so variable. Some membranes had a lot of endothelial cells, some membranes had a lot of fibrosis, some membranes had barely any endothelial cells. So as he kind of alluded to, there's a spectrum of sort of the types of cells that we found in those membranes. They weren't all uniform. Some membranes had a lot of T cells, which
So is it possible there's a correlation between parasite quantity and myofibroblast transition?
It's highly possible. So
because
there's no
that
way
would define why some people get a crunch and others don't.
That's very possible that if you have the myofibroblasts are already transformed, you really have nothing to act on. But if you have a lot of these sort of cells in transition, they're very active and and you could induce them. So maybe that may be a key to the question. And we can, unfortunately, we can't really quantify, but we have sort of ratios. We can look at these and try to figure it out.
Just wanted to ask one question. I think great talk. Both the talks gave a lot of inputs. We have Dr. Kritika, and her thesis work at Sankara Nethralaya was on adiponectin. And Dr. Amini, what you found is also related to adipocytes. So it's adipocyte enhancer binding protein 1. So do you see any link? Because she found a relation of adiponectin as a, if I am correct, Ritika is there. I think
Yeah,
it
Harsh.
was, yeah, so it was pro-fibrotic or anti-fibrotic? I'm not very, I forgot your, can you just share that? What do you think there is a link between these two? Because she found adiponectin as one of the pro-fibrotic marker, if I remember correctly, in proliferative diabetic retinopathy.
Yes, Dr. Raju. It's actually, we found that in the initial stages of PDR, we found adiponectin was found to be anti-angiogenic. But in the later stages, we saw its effect on pro-fibrotic effects on PDR patients, like when we treated with the endothelial cells, retinal endothelial cells. So I have a question to Dr. Skillman. So it's been more than a decade, like we found this angiofibrotic switch concept. Why there are not so much of clinical trials on anti-CTGF targeted therapies? And is there any real, is there any obstacles that prevent the combination therapy with anti-VEGF and anti-CTGF? I want your inputs and
We
thoughts
should
on
ask
this.
pharma Yeah, I already discussed it a little bit. We should ask pharma companies. I think for proliferative retinopathy, it would be a very small market, and that's usually not interesting for pharma companies. The interest has been in AMD, in combining anti-fibrotic treatment with anti-VEGF to prevent scar formation, which also, of course, doesn't happen in all patients. And I know that one company has thought of doing a bispecific antibody of anti-VEGF and anti-CTGF, and maybe they're still working on it. But of course, it's hard to tell whether they abandon these projects because they have no potential for the patients, or whether they have no potential for commercialization. And it's not published. They don't publish negative data, so we don't know. But this is it's in the domain of pharma to pick this up and bring this to the clinic now. I think, and of course with anti-VEGF, there was very little solid data of VEGF function in the eye when the big trials were started, and it turned out fantastically. But basically, the main proof that VEGF plays a role in neovascular AMD or proliferative retinopathy is from experiments in patients.
Dr. Schlingemann, I would like to ask you, see, we know that the fibrosis, the process of fibrosis and CTGF going up starts when the inflammation starts along with the VEGF. But it's later on when the VEGF goes down and the CTGF is high, you get the fibrosis component. But what if we handled the inflammatory components? That is, we gave steroids, which is a blunderbuss kind of treatment for bringing down overall inflammation. Use tumor necrotic factor inhibitors to bring down specifically the TNF, and then gave the anti-VEGFs like maybe aflibercept, which also has a role on platelet-derived growth factors. Do you think we may be able to bring down the overall evidence of fibrosis in all these conditions?
Yes, I think so, because you would be intervening very early in the wound healing response, and inflammation is a component of wound healing tissue everywhere in the body. So there must be a role, and probably some of these bone marrow derived cells can also transdifferentiate into myofibroblasts. I don't know whether that is the case in the eye, or whether there was any evidence from your work, Professor Fazi, but we know in wound healing tissue elsewhere that these inflammatory cells, they just contribute to the wound healing process. And they may also play an important role in inducing this myofibroblast phenotype in parasites. So they're not there to do inflammation, I think. They are there to contribute to a wound healing process which eventually seals up a perforated eye or with a scar. So I don't call it inflammation. It's inflammatory cells, bone marrow derived cells, but they're just part of the process that eventually leads to healing of a wound. And of course, in the diseases that we see in the clinic, this wound healing response makes people blind. And like I said, I see an evolutionary reason why these wound healing processes are so robust and so good to seal off the eye, but bad for vision. But what you're saying, yes, if you intervene very early in these components, either in angiogenesis, like with anti-VEGF, we know we can cut down the whole process, which eventually develops into a scar. But with anti-inflammation, we can probably also do that because we take away an essential component of the wound healing response that has, just like clotting, a number of specific steps. But the point is, clinically, I don't think we don't have much of a reason because we can do a pan-retinal, we can do anti-VEGF. In those early stages, we don't need it because we have already very effective treatments. A patient that presents with fibromuscular membranes, who has a big risk for the crunch syndrome, for angiofibrotic switch, there we would like to have something to take out of the system. It may be Professor Fosi's molecule, it may be CDGF. I'm not sure that anti-inflammation at that stage will do the job.
Thank you, sir. Sir, we are running behind time, so we'll move on to the next session. I would request the speakers to open the Q&A box down below where the audience have posted some questions. You can answer the audience questions in the Q&A box. We would like to move on to the next session. Over to Dr. Janani, please.
Good evening, everyone. That was an interesting session. Now we are moving on to yet another interesting topic. Without wasting much time, I invite Dr. Sudarshan Sridharan, Senior Consultant in UVR Department of Sankara Nethralaya. I request to sir to deliver a talk on inflammation-driven fibrosis in uveitis. Over to you, sir.
Dr. Sudarshan?
Good evening. Am I audible?
The
Yes.
slides are not visible.
Slide, can you make it full screen? Yeah.
Good evening, everyone. So, actually, after the last two talks, there have been a lot of questions that have remained unanswered or partly answered. So, hopefully, I'll add some more to the list. So, uveitic fibrosis, we know that this is one of the retinochoroidal lesions where it can partly heal by scarring, or it can have a fibrotic reaction. A non-infective uveitic condition like multifocal choroiditis can also heal by choroidal atrophic patches all over, or it can have a fibrotic reaction depending on different conditions. So why do some uveitic entities heal like this, scar in some patients and fibrose? Is it preventable or at least is it predictable? So let's see. Fibrosis in inflammatory uveitis. So there are some frequently asked questions in uveitic entities. So fibrosis in uveitis, is it a unique entity? We want to know whether there are some specific diseases that are affected. Is the inflammatory fibrosis different from that which happens in other retinal conditions? We want to know whether it's part of the disease or it's part of the healing process. Dr. Talwar is just mentioning that it's probably part of the healing process, but then sometimes in inflammatory uveitic conditions, we seem to be having it along with the disease process. So let's see whether it's both, whether it's an exaggerated or exuberant response, or it's anything related to the treatment. So When you look at the list of questions, let's start off with the fact that there is a unique entity by itself. Talking of progressive subretinal fibrosis and uveitis from our student days, we know that, in fact, actually, I guess Fuchs probably reported it or mentioned about it about many decades before Newsemblatt and Palestine and others reported it. They ruled out other possible etiologies which was prevalent in that area based on their available investigations. And they found that once there has been fibrosis beneath the macula, it is reasonable to assume that these are irreversible, and so is the vision loss. But one interesting fact which I found in this paper was the last line of the discussion, which showed that there is much to learn concerning the pathogenesis of these ocular inflammatory diseases. So it actually brought a smile on my face that the current status almost seems to be the same even today. When you're talking about a unique progressive subretinal fibrosis syndrome, then it can also have a similar response in other multifocal choroidal lesions. A multifocal choroiditis having a unique course in a young patient, a female preponderance and bilateral. See, these acute course mimics other uveitic entities and we need to rule them out. But in chronic phases, they have this typical subretinal fibrotic zones and they can have a progressive subretinal fibrosis response. They did a chorioretinal biopsy and histopathology and immunofluorescence and found that probably RPE is the culprit. More details about it, Dr. Biswas will be discussing later. But then I just want to tell everyone that the few important takeaways from the past literature, especially from the initial papers, is that progressive subretinal fibrosis syndrome with uveitis is a unique entity. But we should also remember that a similar response can be seen in other entities. So we need to rule out those other causes and treat those primary uveitic entities. Fibrosis may be away from the posterior pole, it can be in the periphery, but due to the significant inflammatory response, you can even have a cystoid macular edema away from the fibrotic response in progressive subretinal fibrosis. And since there is a diffuse retinal involvement, ERG was found to be helpful. So in those days, with all those no OCTs and no big edges, what we have now, almost 40 years ago, they probably had all the information what we have even now. So cut to 2025. What do we know more? We know that fibrosis is scarring and formation of excess fibrous tissue, but the basic issue is the chronic inflammation, the cytokine imbalance, and the oxidative stress. This excessive wound healing response leads to the deposition of the extracellular matrix proteins, and the scarring and tissue remodeling occurs. The basic mechanism is persistent immune activation. The inflammatory cytokines are released, and this triggers the fibroblasts, which lead to excessive cellular matrix deposition. There are other mechanisms like epithelial mesenchymal transition, dysregulated matrix remodeling, where there's an imbalance between MMPs and the tissue inhibitors of metalloproteinases, and vascular leakage and hypoxia. Ultimately, the story is that the ECM deposition happens. So how is fibrosis in uveitis different from others? The important thing is that it manifests as a subretinal fibrotic lesion when compared to other retinal diseases where the fibrosis is on the retinal surface. It can have a fibrosis on the retinal surface, PVR and RD, but here in inflammatory fibrosis, it can progressively enlarge and coalesce, leading to significant visual impairment. The progressive subretinal fibrosis uveitis syndrome that we call. But even in other retinal surfaces, retinal diseases, in neovascular AMD, you can have a subretinal fibrosis following a CNV. There's a big list of diseases, more commonly the VKH, subretinal fibrous uveitic syndrome, multifocal choroiditis, and infections such as ARN or toxoplasma. So let's see a few of them. This is a multifocal choroiditis, like choroiditis, which we see commonly in India nowadays with quantiferon and MAN2 being positive. This was treated with ATT and steroids. But then during the final follow-up this month, we found that there are areas of choroidal atrophy all over the fundus, but there are significant fibrotic reaction at the posterior pole too. So what has this taught us? It means that the healing response in fibrosis is not always uniform. It can occur in the same eye in different forms and in different areas of the retina. So not all those areas which are affected by choroiditis heals by fibrosis. So is it the same in infectious uveitis? This is one ARN where aqueous tap was positive for HSV virus, and we treated with IV acyclovir, and the peripheral lesions started, the active ones here, started resolving. But then, to our surprise, even though the peripheral retinitis lesions were resolving, it developed inflammatory syndrome, and this had to be treated along with IV acyclovir with anti-VEGF injections. Eventually, even that healed, and this was reported by Dr. Biswas and Bhuvaneshwaran. But this indicates that, as we saw in choroiditis areas where you can have fibrotic reaction at different points where choroid is involved, here we find fibrosis occurring at the same area of, not necessarily the same area of retinitis or choroiditis. It means you can have fibrotic reactions where clinically there is no retinitis or choroiditis. This again confirms that it is not just a healing process. Probably there's an inflammatory trigger that's going on. It triggers an inflammatory cytokines, which can probably act at areas away from the actual site of choroid or retinal involvement. So talking of choroidal neovascularization or inflammation related, the type 1, there is a formation of CNV and subsequent fibrosis. As there is a discussion going on, it's part of the ocular wound repair process probably. And this wound repair process, if it's not properly balanced and if the stimulus persists, then probably leads to fibrogenesis. So our aim is probably to make sure that the stimulus doesn't persist. So another common infection other than the viral one is a toxo like retinochoroidal lesion, like in this young boy, where we treated and it resolved very well, and the vision improved to 6/9, and the lesions really resolved quite well. But during follow-up, we found that there was an activity with the fibrovascular membrane formation. An interesting aspect in this is that along with this fibrovascular membrane, there were vitromacular traction. So when you have this situation where there's a traction along with this fibrotic reaction, you obviously need a surgical management at this patient. So this was vitrectomy with ERM removal was done. And interestingly, the histopathology of the fibrovascular membrane showed chronic inflammation. So was the vitreous aspirate. But more importantly, PCR was negative for all these infections. It's important here to remember that in surgery in uveitic fibrosis can be challenging. It can, the thick PVD or the vascularized ERM can have strong fibrous attachment and it may be difficult. But more importantly, in this patient, intraocular specimen was negative for all the infections at the time of vitrectomy, and the response probably was an exaggerated response post-infection resolution. Or is it some kind of a rebound or a recovery or a paradoxical kind worsening? I don't know. So what we know is that infective entities producing significant inflammation, such as ERN or toxo, seems to be at increased risk of fibrosis or fibrovascular membrane formation. So when inflammation is controlled, can we expect fibrosis to be less? So let's see one case where there was extensive toxo, which was exaggerated due to intravitreal ozurdex. This is ozurdex inside with a significant extensive necrotizing retinitis types. But then the vitritis and inflammation persisted with coalescing lesions progressively. So we had to undergo vitrectomy. We had to do vitrectomy and removal of the implant. So this means that ozurdex did not help. Sorry about it. So this means that the local anti-inflammatory therapy such as steroid injection may not be sufficient to prevent fibrotic reaction, and it's possibly a systemic trigger, and the systemic treatment might be helpful. So does it mean that it occurs only if choroid or retina is involved? Not so, because we can have a pars plana fibrosis in intermediate uveitis, and we can have fibrosis in exudative arteries. VKH is a significant vision loss is caused when fovea is involved. Subretinal fibrosis is noted in about 8 to 10% of VKH. There are risk factors of a longer disease duration and recurrences. Bullous RD has an 8-fold increased risk. This has also been reported in sympathetic ophthalmia. So we try to answer all these questions, but if you look at imaging, we know that OCT features of a hyperreflective lesion or a disruption of a normal retinal architecture can be helpful. Inflammatory and non-inflammatory CNVMs can be differentiated in OCT, and associated fluid or degenerative changes can be made out. But fibrosis doesn't indicate the end of a disease process, like in this patient where an active VKH was treated aggressively and it resolved with fibrotic reaction. But during the follow-up, there were cystoid spaces, and we were wondering whether it's a CNVM wrap-like lesion at type 3-1 because of the speck of hemorrhage. So here, Octa may be helpful. There have been studies showing that Octa is helpful in the initial diagnosis and in the follow-up. But more importantly, this was quite interesting for me. This was a polarization sensitive optical coherence tomography where they found that PSOCT provided additional information to distinguish subretinal fibrosis from other tissues within the subretinal neovascular lesions. So this probably need to be studied even more. So we know now that the vision loss is because of the scarring of the macular fovea. So we need to treat them with anti-inflammatory medications such as systemic steroids. Immunomodulators such as cyclosporin and tacrolimus may be helpful. Biologicals, as we are talking about anti-TNF alpha inhibitors, may be helpful in controlling the inflammation and preventing fibrotic remodeling, and surgical intervention in specific cases. But in future, the investigations are going on about targeting the fibroblast activation. Newer therapies targeting the pathways such as YAP and TAZ are going on. TGF beta inhibitors, pirfenidine may be helpful, seems to be having promising results. Gene therapy and stem cell therapy seems to repair the damaged tissue and reduce fibrosis. So as we are discussing, is it a keloid in the eye? We don't know. So fibrosis is a healing process, but perhaps part of the disease too. I'm just triggering. Fibrosis can occur in areas involved and away from it too. But more importantly, it will be helpful if there are specific imaging markers which can detect which patients will go into fibrosis, and probably we can treat them aggressively. And individuals who are susceptible for at risk may be helpful in prevention. But again, talking of aggressive treatment, are we perhaps hastening it by short-circuiting the smooth normal healing process leading to fibrosis is a question I would like the panelists to answer. Thank you, sir.
Thank you, sir. We'll reserve the discussion at the end of the talk. Now, quickly, I call upon Dr. Muna Bende, Deputy Director, Sri Bhagavan Mahavir Vitreoretinal Services, who needs no introduction for presenting fibrosis in exudative artery. Over to you, ma'am.
I'm sorry. Can you see my slides?
Yes, ma'am.
Yeah. So good evening, everyone. And my talk today is a little bit of a continuation of what Sudarshan spoke and a little bit of the first session as well. Fibrosis is a response of tissue to injury, which could be either mechanical, metabolic, response to inflammation, ischemia, or degeneration. It's characterized by infiltration by inflammatory cells, neovascularization, altered permeability, proliferation of fibroblasts and fibroblast-like cells, and modification of the ECM. The best examples probably of fibrosis in the eye, in the retina, are those induced by hypoxia and neovascularization. Exudative retinal detachment causing fibrosis is a little rare. However, there are a few conditions where exudative retinal detachments are associated by the fibrosis, and these are in bold. That is FEVR, Coates, and central serous chorioretinopathy, which I'll be speaking about today. We've already discussed on inflammation and infection. Certain tumors like VPT and choroidal hemangiomas can also have some fibrosis. Now, the recent classification of central serous retinopathy divides it into simple, complex, and atypical. And what we do know now is that probably the bullous variant of CSCR, the atypical variant, is the one that is most associated with fibrosis. And this was known as early as 1995, where Schatz presented the series of cases. And he concluded that subretinal fibrin and other ECM molecules appear to simulate the retinal pigment epithelium to undergo fibrous metaplasia, which results in a subretinal fibrotic scar formation and all other sequelae. Not much has changed since 1995. We had our own series from Sankara Nethralaya, where subretinal fibrosis and bullous retinal detachment associated with multifocal central serous retinopathy was seen in a series of young male patients, and a lot of them were associated with systemic steroids. Stoppage of steroids and performing laser photocoagulation helped in resolution. Now, sometimes CSR can be mistaken when it is presenting with fibrin, as in this gentleman who was seen in July 2012 elsewhere. And if you see this area of fibrin, this was diagnosed as choroiditis. The patient was treated with steroids. and then developed this fibrinous lesion in the right eye. The lesion in the left eye increased, and subsequently patient was referred for non-resolving choroiditis with exudative retinal detachment. And this was the montage fundus photograph showing fibrin in both eyes and some scar tissue formation as well. The patient also had some neovascularization. And if you look at the fluorescein angiogram, you realize it's a multifocal central serous retinopathy. And this was his OCT, which showed extensive fibrinous deposition in the subretinal space. So what happens? How does fibrin become fibrosis? Because in fibrinoid CSR, we tend to see fibrosis. The first important thing is there must be a significant hyperpermeability of the choriocapillary's fenestrations, because you need to allow a large molecule such as fibrinogen to escape through it. And what happens when it escapes? The fibrin overlies the RPE cells, and these cells lose their normal epithelial morphological features. They undergo fibrous metaplasia, and this results in subretinal fibrosis. And overlying these areas of fibrosis, one can also get some amount of cystoid degeneration, and this is things which we do see in long-standing CSCR. Now, this is a gentleman, I'm showing only his right eye. He has bilateral chronic central serous chorioretinopathy. He's now 54. He's had it for over 15 years. You do see pachychoroid here. You see the large choroidal vessels. You see that there are cystoid spaces in the peripapillary area and fibrin. You see this homogeneous area here, as well as an exudative retinal detachment. And despite treatment with laser, despite eplerenone, the disease continued. And now he has this fibrotic scar with overlying cystoid degeneration. And the ICG shows extensive choroidal hyperpermeability. But what we've learned so far is choriocapillary's hyperpermeability is essential for development of fibrin in CSCR. And can it be prevented? Probably early laser treatment can help prevent the fibrosis. Jai will be talking on inner choroidal fibrosis, which is believed to be a marker for CSCR, so I will not talk about it. But there's this interesting new entity that I read when I was preparing for the talk, something called SMAC, or stellate multiform amelanotic choroidopathy, which has distinctive hyperreflective fibrous-like changes in the anterior choroidal stroma. It can be associated with subretinal fluid and could be either the same different entity or another form of central serous chorioretinopathy. We know very little about this, so there's nothing much more I can tell you. And this is another form in which you can see extensive areas of subretinal fibrosis. Probably something we understand much better is Coats disease, where we know there can be both macular fibrosis as well as extramacular fibrosis. The macular fibrosis usually occurs as a result of intraretinal neovascularization, which again is secondary to the deposition of lipid exudates. And the vessels that grow almost like a type 3 CNVM or a RAP lesion. You see this patient with hard exudates in the macula and the peripheral telangiectasis. 1 month later, the exudates are organized. And then at 9 months, you see it becomes a fibrous scar, which is something we often see. And the fluorescein angiogram looks like a RAP lesion. And this is associated with a worse visual outcome. And this is a heel lesion where you just see a quiet fibrotic scar. However, we also get vitreoretinal fibrosis in Coats disease, and there are definitely two schools of thought in it. There was this study by the Shields group presented in British Journal of Ophthalmology 212, which said that intravitreal bevacizumab was associated with a higher incidence of vitreoretinal fibrosis in patients with Coats disease. And they also went so far as to say caution is advised in the use of bevacizumab for patients with Coats disease. And these were the examples they showed with increasing fibrosis in patients who were treated with bevacizumab. However, there was another study in 2016 which showed that fibrosis was more likely if there was extensive retinal exudation, and the larger your exudative retinal detachment, the more amount of fibrosis. And they said that treatment-induced fibrosis was not that common. However, a pooled analysis in 2019 did show that there was a role for treatment, especially the combination of anti-VEGF agents and cryotherapy, as opposed to anti-VEGF agents and laser or laser alone. So one thing we do know is to proceed with caution with anti-VEGF agents in patients with Coats disease. And as far as the long-term prognosis of Coats disease, the study from India showed that 3 of the poor prognostic factors, vitreoretinal fibrosis, subretinal gliosis, and traction or combined retinal detachment, indicating that fibrosis is a dangerous end stage of Coats disease. This is a young girl whom I have been seeing from the age of 11. She's now 19, and this is how she presented with extensive exudation. She already had a little bit of fibrosis and vascular telangiectasia in the periphery. She had multiple sittings of laser photocoagulation and was relatively stable till one day she appeared with extensive amount of exudation going above the disc with an exudative retinal detachment. She had one more sitting of laser and ranibizumab. She was okay for a couple of months and then suddenly came with massive exudative detachment and also a large amount of pre-retinal fibrosis and required surgery with peripheral retinectomy. The other exudative retinal detachment that I'll be talking today is FEVR, which is the most frequent cause of exudative retinal disease in pediatric age group along with Coats. Basically, there's an avascular peripheral retina due to abnormal retinal angiogenesis and variable degrees of retinal neovascularization, subretinal exudation, and vitreoretinal traction can occur. And there are various mutations that are associated with FEVR. Basically, FEVR is one of the Wnt signaling associated vitreoretinopathies, where the Wnt pathway is associated with cellular stabilization and control of angiogenesis. So any abnormality leads to these changes in the periphery, incomplete regression of the primary hyaloid system, capillary dropout, endothelial budding, blood-retinal barrier breakdown, exudative, and then tractional retinal detachments. And these are the various stages. It starts off with exudation, and later on from stage 3 onwards, after extensive exudation, you can then develop a tractional or fibrotic component. Now, what happens? Why the fibrotic component? There is a pathologically adherent and contractile vitreous. And these hyaloidal sheets, as most of us who have operated patients with FEVR, can be difficult to visualize intraoperatively, and there's a very high risk of recurrent premacular proliferative tissues in these eyes because the initial surgery is always very conservative, just intended to support the periphery and not peel off the membranes over the macula. Worsening traction after treatment then ranges from 0% to 75% in various studies. We've discussed the angiofibrotic switch. That's one of the reasons worsening traction does happen. And also the disorder of the Wnt signaling pathway that modulates cellular and tissue differentiation. And this was an interesting study which analyzed the predisposing clinical features for worsening of traction after treatment for FEVR. And they found that laser treatment had a significant incidence of worsening of traction. This is a patient 3 months post-laser showing the tractional detachment, and this patient 19 days post-laser. This is one of our own patients who was genetically confirmed FEVR with a strong family history. You see the peripheral fibrosis that has already begun at presentation, epiretinal membrane on the disc, peripheral neovascularization, and a lot of exudation. The first surgery was just a vitrectomy, scleral buckle, and he did well. A couple of months later, he developed recurrent fibrosis Then he underwent epiretinal membrane removal and peripheral cryo to the vascular malformations. This was the other eye which had laser. This was after membrane peeling. You see the cystoid changes have reduced. And then a few months later, he came back with reproliferation and recurrent epiretinal membranes. So fibrosis in exudative RD, it can be either subretinal or preretinal. The best example for subretinal fibrosis is CSCR, where the role of leaky choriocapillaries is known, and there is a switch from fibrin to fibrosis due to the break in the RPE as well, which allows the fibrin to layer over the RP, leading to fibrous metaplasia. Stoppage of steroids, which are commonly given either mistakenly or intentionally, and early laser photocoagulation may prevent this. Coming to Coats disease, you can have a combination of subretinal fibrosis and preretinal fibrosis. And it's the conversion of the exudative to the tractional retinal detachment and the role of the abnormal vascular element that precipitates the preretinal fibrosis. Again, in FEVR, you can have conversion of the exudative to tractional RD due to fibrosis. You have a pathological vitreous in the presence of non-perfusion leading to neovascularization. Here you have the role of both VEGF and the winged signaling pathways. There are other conditions that I haven't mentioned. These are vasoproliferative tumors, choroidal hemangiomas, and B-dumped. Thank you very much for your patient listening.
Thank you, ma'am, for such a fascinating talk. Before going to discussion, we have a quick presentation by Dr. Jyotirmay Vishwas, Director, Department of Uveitis and Oculopathology, Sankara Nethralaya. Over to you, sir. He will be talking on histopathological aspects of fibrosis in inflammation.
Good evening. I'd like to thank Dr. Rajiv Raman for giving us the opportunity in the UVA department. I'll be talking about fibrosis in uveitis. Dr. Sudarshan has elegantly talked on various facets of fibrosis in uveitis and particularly subretinal fibrosis. I'll be talking about some of the examples of basic pathology of fibrosis in uveitis. This is an elegant study done by Dr. Lim and Shunpek Chi, Robert Nassimrad and Chi Chao Chen from NIH, and they had a immunopathology of progressive subretinal fibrosis in a case of sympathetic ophthalmia. This is a patient, 40-year-old man, presented with the left eye total retinal detachment following multiple vitrectomy in the right eye, followed by multiple vitrectomy in the right eye for retinal detachment. Small peripheral retinal holes, snowbank, and inflammatory nodules in the ora serrata are observed during left vitrectomy. Both eyes deteriorated rapidly to blindness with progressive subretinal fibrosis and inflammation over 3 months, and the patient was unresponsive to prednisolone and azathioprine. This eye is here is the initial presentation, the top two pictures, and you can see the extensive subretinal fibrosis occurred in spite of immunosuppressive and steroid therapy. Immunopathology of the chorioretinal biopsy of the was done, and that showed. I would be showing you the slide of the case of from the one, and you can see that extensive inflammation was seen in the chorioretinal biopsy. And this chorioretinal biopsy was immunohistochemical study was done. CD3 is the T cell marker, and there was a center of the fibrosis. You can see that the black color, that the T cell positivity. There was also CD20 positivity was seen diffusely in the membrane, and also the macrophages CD68 positivity was seen. So in these cases, the underlying pathology of the subretinal fibrosis was the inflammation. There is one other paper was a progressive subretinal fibrosis and blindness in a patient with multifocal granulomatous chorioretinitis, and this is a patient, 4 eyes of the 3 patients because of multiple choroiditis and massive subretinal fibrosis. During a period of several years, the healthy elderly patient developed severe vision loss. Histopathological examination was done, and I'll be showing you the pictures. And this showed basically subretinal fibrosis as well as the degenerated and fragmented Brooks membrane and chronic uveitis. No infectious organisms were identified by special stains or electron microscopy. And this is, let me show the pictures of it. You can see that how extensive fibrosis was seen in this patient with the red arrows showing the subretinal fibrosis in this patient. And there is a rupture of the Brooks membrane was seen. And here is the example of subretinal fibrosis, rupture of the Brooks membrane and chronic inflammation, and as well as the multinucleated giant cells seen on either side of the break in the Brooks membrane. And this macular region showed granulomatous reaction, separating this is the middle picture. Macular region showed the subretinal fibrous plaque from calcified Brooks membrane, and there is a Brooks membrane rupture, and you can see the inflammatory cell infiltration. And third picture is showing that chronic inflammation in the choroid and the defect in the Brooks membrane. And here you can see the degenerated collagen fibers and extensive inflammation surrounding that collagen fibers, as well as you can see that a red arrow indicates the giant cells, a granulomatous reaction was seen in the eye. So this is the fundus massive showed a mass lesion in the subretinal fibrosis, which you see in OCT pictures, which you see, and this was a very precious slides showing the histopathology of the subretinal fibrosis. But underneath the fibrosis, you can see the chronic inflammation, which are indicated by the red arrow, and the rupture of the Brooks membrane. And this is the necrotic retinal pigment epithelium is seen and is separated from the Brooks membrane, a layer of eosinophilic debris and mantle of histiocytes beneath the Brooks membrane. On the inner surface of the Brooks membrane, you can see the histiocytes, and there is a chronic inflammation was seen in the choroid as seen in this picture. So this is the subretinal fibrosis in uveitis patients in progressive subretinal fibrosis. So retinal fibrosis can occur in inflammation other uveitic entity, particularly in pars planitis, which you call snow banking. I have got the chance to have an eyeball, which was a painful blind eye, and I could see that retinal fibrosis, vitreous membrane and subretinal membrane was seen in the eye, in the pars plana region. Extensive fibrosis, vitreoretinal fibrosis was seen in the retina. And the inflammation was the ciliary body, vitreous and peripheral retina. And this is a clinical photograph of the snow banking. Basically, this snow banking is fibrous tissue, and if you see the histopathology, but this photograph is taken from Dr. Narsingh Rao when I was working over there. I collected this photograph, and you can see that this is the ciliary body area, and one can pars plana region, and you can see the fibrous tissue which act as a plaque in the pars plana region, and there is hardly any inflammatory cells are seen in this condition. But I have bought an enucleated globe, which was a young boy who has got extensive pars plana membrane, and I did that immunohistochemistry as well as the histopathology. This is yet to get published, and I did that fibrous tissue with a special stain, glial cell fibrillary acidic protein. There's a brown colors. One is showing the glial fibrillary acidic protein positive material, and you can see that Alcian blue material positive, showing that acid mucopolysaccharide substance. But basically, this fibrosis tissues is also surrounded by inflammatory cells, and these inflammatory cells were macrophages, CD68, and CD3 T cells. CD20 B cells was predominantly less, but mostly the cells were T cells. So indicating that it's a T cell driven process which leads to inflammation and subsequently leading to the fibrosis in the pars-plana region. So these CD3 cells is predominantly T suppressive cells, CD8 cells for CD8 positive T cells, and you can see that whole eye photographs is taken in the pars-plana region. Is a massive fibrous plaque was seen in the region. So in summary, fibrosis is a sequelae of inflammation, but basic underlying pathology is probably chronic inflammation. Many of the conditions like chronic, multifocal choroiditis or pan-uveitis, we can give the subretinal fibrosis and sympathetic ophthalmia, Vogt-Koenig harder disease. I tend to overtreat such patients with the corticosteroids for prolonged period of time. I find that low dose of steroid can prevent or can reduce the formation of fibrosis. As a pathologist, I feel that there is a subclinical inflammation is present in many of these conditions and which can be regressed, which can be controlled by usage of low dose of steroid or immunosuppressive agents for a prolonged period of time. Thank you very much.
Thank you, sir, for an excellent talk. Now I welcome Professor Dr. Amod Gupta, Professor Emeritus, Advanced Eye Care PGI Chandigarh for the panel discussion along with Dr. Bishwas. So, sir, Dr. Amod, sir, I have a question for you. So, do you think with the recently, upcoming biological agents in selected conditions where we anticipate more fibrosis, early initiation of these biological agents will prevent the fibrosis to some extent?
Well, let me give a little background because discussed almost for last 90 minutes. I'm sorry I missed out a bit of Sudarshan's and Munna Bhendi's talk because of power failure at my end. I would like to just sum up by simply stating for people who are not basic scientists that fibrosis is a wound healing response. Whatever may be mechanical, ischemic, inflammatory, or any insult, it would lead to a wound healing response. Fibrosis is when that wound healing response gets exaggerated, gets out of hand. Now we have to see what that insult is. Is it the ischemia? And I think that was Dr. Dinesh Talwar did discuss about dealing with that in diabetic retinopathy session. So can we preempt the development of exaggerated response? Sure enough, because what Dr. Jyoti Biswas is showing the end stage where the eyes had to be enucleated or biopsied. So if we can preempt that, because we don't know, so far there are no markers to tell, and this is what Sudarshan also mentioned, that there are no markers to tell who is going to develop a keloid-like or exaggerated fibrotic response. For we need to control inflammation at the earliest. And this is what we have seen in patients like VKH, for instance, who are treated late, or those who reach into a chronic recurrent uveitic stage are the ones who develop subretinal fibrosis. So we have to cut down on the inflammation, control inflammation at the earliest with the heaviest dose possible, of course, the corticosteroids. But one point, if you noticed in Dr. Jyoti Biswas, and this is the work from Dr. Narsingh Rao as well as Rosenblatt's lab, where they have found that there are CD20 cells positive and probably these are B cell driven responses to the RPE and Brooks membrane, injury. that leads to the subretinal fibrosis. So rituximab is possibly a good, if we expect that this could be, and there are only case reports of rituximab use to control inflammation and prevent development of fibrotic response in some of these patients. So that is one thought on that. Now, the second is, I think the example, classic example is of weak age disease. And some of these patients who develop, there has to be a disruption of RPE cells from the in situ, wherever they are lying in a planar fashion. Unless you all these cells, like we had that excellent example by Professor Fawzi, where she has shown that pericytes around the capillary endothelial cells, they are the ones which are transdifferentiating into myofibroblasts, which are laying down the fibrous tissue and extracellular matrix. Now, likewise, the Muller glial cells in the retina, they are fixed cells. The RP cells are fixed on a basement membrane. When these cells are in situ, they will not transdifferentiate into myofibroblasts. So in the retina, they are a little different from the fibroblasts that they will happen in the choroid. So you will have fibroblasts in the choroid, but in the retinal, you will have the Muller cells as well as the RP cells, but they need to be disturbed. So if you lose their cell adhesions, lose them, from their basement membrane, they will be acted upon by TGF beta to kind of transdifferentiate into fibrous tissue laying down myofibroblasts. So you have to control. And people have shown that, very elegant example in VKH, those who have a very high bullous detachment, they are the ones who are going into more often into fibrotic responses. Okay, compared to those who have less. Likewise, you may have sheet-like fibrous response if there is a diffuse choroidal granulomatous inflammation, because all these inflammatory cytokines are going to recruit these stationary cells which are capable of transdifferentiating. But you would see some patchy responses, like Sudarshan was mentioning, some patchy responses of fibrosis are probably because of the soluble factors, which are, all these growth factors are soluble. The inflammatory factors are soluble. They can act upon the stationary cells anywhere in the retina and in the choroid. So that is what I would like to sum up my what I feel as a non-basic scientist, the understanding of how fibrosis occurs in the retina and choroid in the inflammatory diseases. So use of biological agents, adalimumab, use of rituximab, and control the inflammation at the earliest. I think that is what. And one small point I would like to make, that there may be, and this is a thought for some kind of future research, not only for diabetic retinopathy, but also for inflammatory diseases. Like one classic example is the VKH disease. People in Mexican mestizo population, they are showing almost like 40% patients of VKH developing extensive subretinal fibrosis versus just less than 2% in North Indian population that we have seen in Chandigarh. Okay, so there is probably a predisposition which we knew about sarcoid, like the Black African ancestry. They are the ones who show a lot of fibrotic response. But here we know that the Mexicans, white Mexicans, the Mexicans, they show, and this is what I saw when Dr. Narsingh Rao was first presenting his VKH patients, which had more of these Mexicans in the LA area. They were extensively scarred. And this is the question I asked: how come you see such extensive subretinal fibrosis, pigment migration that we don't see in North Indian population? So probably we need to look at from that point of view, are there racial differences in all diseases of the way our patients fibrose versus the other racial groups who would fibrose. Yeah.
Yes, that's a very nice thought, sir, and thank you for your inputs. And a quick question to Dr. Munna, madam. Are there any clinical or OCT biomarkers suggesting a likely future fibrin response in CSCR by Dr. Paritosh? Ma'am, you're muted, ma'am.
I think that's not really been looked at, but what comes through all the references are leaky choriocapillaries. And I think Jay in his talk is going to talk about inner choroidal fibrosis as a biomarker, but leaky choriocapillaries, RP, RIPS, those are more likely, and of course, usage of steroids, they're more likely to have exudative response in CSF.
Thank you, ma'am. And there is yet another question from the audience. How do systemic fibrotic diseases like scleroderma or idiopathic pulmonary fibrosis relate to retinal fibrosis? And can we draw parallels for treatment? Anybody would like to?
There are case reports of ectodermal dysplasia with subretinal fibrosis and uveitis syndrome. Anecdotal reports, not too many. And I don't think idiopathic pulmonary fibrosis, there is any reported case of subretinal fibrosis and uveitis or ocular inflammation. That reminds me that people have been using these TGF beta blockers for idiopathic pulmonary fibrosis for a long time. And these drugs, I think Sudarshan did mention some of the drugs which are available even in India. They have not been tried for slowing down the progression of subretinal fibrosis or ocular fibrosis, possibly because of the risk-benefit ratio compared to aggressive anti-inflammatory therapy, which might be more effective than these. But they have been tried, and people have tried for corneal fibrosis. They have used metformin. They have used for glaucoma some of the drugs like ROCK inhibitors, which also prevent fibrosis. So these are some of the agents, but otherwise, I'm not sure if people who show exaggerated response in lungs or in even skin wounds, would they show the same response in the eye? I doubt very much. I think it's absolutely a local phenomena. Absolutely. I think it's a very regional, local phenomena rather than a systemic phenomena.
Thank you, sir. For want of time, we come to the end of this session. Now I welcome Dr. Jayaprakash, Senior Consultant, Sankara Nethralaya, to moderate the next session.
Good evening once again. After two interesting sessions, we'll go on to the third and final session of the day. I would like to invite the first speaker, Dr. Jay Chablani, to talk to us on inner choroidal fibrosis in CSCR. Dr. Jay Chablani is our own alumnus and was earlier working at L. Prasad Eye Institute and currently is at the University of Pittsburgh.
Hello, everybody. Good evening. Thank you so much for the kind invitation. I really enjoy this meeting every year, but unfortunately today I'm in the clinic, so I'm not able to listen to all the talks. I wish I could actually listen to all the discussion, but I will quickly get on to something on CSCR, which we recently reported called inner choroidal fibrosis. And while in between listening to talks from Amani and other speakers, I just thought that I wish I could take the biopsy of the choroid in CSR patients. But unfortunately, we had to use the optical biopsy, that is OCT. So let's talk about what is inner choroidal fibrosis. These are my financial disclosure. None of them are relevant to this talk. Before I really move on, I would like to acknowledge two people here, Sarang and Niroj. They both are in LVP. I had the opportunity to work with them on this interesting project where we actually extensively looked into multiple cases and trying to figure out this new biomarker. So as we all know that CSCR could be of two forms, acute or chronic, but we also define this as simple or complex. CSCR based on multimodal imaging. Imaging has always played a very significant role in CSCR, particularly wide field imaging. And we also understand that, there are various imaging biomarkers which we have been using for years. We definitely use autofluorescence in every imaging. We look into multiple leakage sites or window defects and fluorescein angiography. We certainly use ICG to look for choroidal hyperpermeability. OCT is one of the best imaging modalities. And now OCT angio is also playing a role, and we definitely look into PD and try to understand how significant the disease progression is. So let me take you through a couple of cases. I will not be able to share all the cases because of the limited time, but I thought that, let me share what we started with, how we came up with this new biomarker. This was a 44-year-old gentleman's known case of CSCR for last 5 years. When he presented, his visual acuity was 20/80, 2200. This was his multimodal imaging. I'll just take you through these pictures. I'm sure that this is what you're seeing now is not uncommon to see in patients with CSCR, where you have this very subfoveal, subretinal fibrotic material here, right in the central area. You see the autofluorescence. You are able to see these hypo areas here in both the eyes, and here some areas of hyper. Again, very common to see in patients with CSCR. But when we look at the invasive angiography, what you see is that there is no blood flow here, especially in the left eye ICG. You can see that hardly there is any blood flow. There is hardly any hyperfluorescence. A lot of hypo areas involving and corresponding to this scar tissue, and typical leakage in the periphery with some hypo areas on invasive angiography. OCT angio also clearly shows the area of choriocapillaries loss. Again, which we see very commonly in CSCR, and you can see multiple areas of flow voids as well. Very typical CSCR, but what I want you to focus on OCT is that if you look at the OCT clearly shows that there is some scarring here in the subretinal space. There is no fluid, very minimal, one small pocket of IRF, small shallow PED here. The choroid is thick, again, not uncommon in CSCR. But what we are seeing very distinctly is that this very well-defined area of hyper or heterogeneous reflectivity right here, just under the scar tissue, what we were seeing. But what I want you to notice here is that you can clearly see that this lesion is very much limited within the choroid. It is not, unlike a CNV scar, it is not like really merged with the RPE or Brooks membrane, but it looks like a pretty well-defined. Look at this left eye, something similar where you have a clear distinction that this lesion is very much into the choroid. You have these chronic cystic changes, again, not uncommon in CSCR, a slight excavation going on here. But in this particular lesion, you can see that you can barely see any choroidal vessels. You feel that there is some sort of fibrotic scar within the choroid, which is differentiated from that. So then this is the next case of a 59-year-old gentleman, 10 years history of CSCR, 2200 right eye, and 36. So this is a patient with right eye finding where we see, again, similar scarring tissue, which we see similar findings on invasive angiography test, as well as an OCT angio, where you can clearly see that there is a significant ischemia, almost no choriocapillaries, extensive leakage on the ICG in the surrounding areas. But this area is not leaking at all. Similar thing in the other scan on OCT angio as well. But now let's look at the Swepsos OCT data, where you can clearly see the large choroidal vessels are seen, some disruption of the choroidal tissue, but again, there is a very distinct material or some form of fibrosis right in the choroid, which is very well differentiated from the RPE. And I think this is what we kept figuring out, that, why does this happen? And then we saw that probably there is, again, what Dr. Amod Gupta was mentioning, that probably there is some fibrotic changes happening here in the choroid itself, which are again very well differentiated from what we see in typical CNV. So we call this as inner choroidal fibrosis, ICF. We looked into our data set, and we only found 5 cases, 5 eyes of 4 patients. You already saw one patient which had bilateral finding, and they all were male, 100%. They were bilateral cases of CSCR, but 3 patients had only unilateral ICF. And this was the distribution here. You can see here that, most of them are in the same range of 44 to 64, which is again a very common case where age group where we see these chronic cases. Visual acuity range is ranging from 2080 to 2200. Presence of CNV was there in 4 eyes, as we saw. One eye had the last case which I showed you did not have CNV but had only ICF, because that is what we kept going back and forth and figuring out, that why it is so differentiated from CNV scar. These patients did receive some anti-VEGF treatment. The final acuity, as we can expect, it did not improve much. So we call this as a separate scar rather than a subretinal scar. We call this as an inner choroidal fibrosis. Just to take you through again, there on OCT, the ICF looks as if it is a heterogeneous hyperreflective lesion, but you can clearly see that this scarring or this fibrosis is so different from subretinal scarring, which we see, which has a lot of shadowing. These eyes don't have shadowing. Here you can see that the choroidal fibrosis is not causing shadowing. I don't have histological data where we can actually try to understand what kind of cells are there, but definitely some form of fibroblast, which Dr. Amod Gupta was mentioning. One more thing which we realized, that if you really look carefully, you can see that this finding is totally separate and pushing these Heller vessels away. They are like very much localized, as if like encaved there. So again, a very interesting observation. In these cases, as you can imagine, these were all chronic cases. We did see severe attenuation of the RP, ellipsoid zone, and outer retinal structures. We also noticed that some of these patients had IRF, SRF, serous pigment epithelial detachment, as we saw in earlier cases. We also saw pachyvessels, and we did notice there was an increased subfoveal choroidal thickness. And three out of 5 cases had choroidal excavation. So we believe that definitely some form of significant choroidal scarring fibrosis is going on, which is also contributing to the FCE. We already saw these pictures. FA shows hypofluorescent in the initial phases, and then there could be RP window defect changes, which we see very typically in these cases. ICG also shows hypofluorescent, which does not leak in the late phases, again establishing the evidence of fibrotic changes in the choroid. And OCT angio shows flow voids in the choriocapillary swab. I know when I presented these cases earlier, a lot of people brought in SMAC as one of the differential diagnoses, and this is one of my patients with SMAC, which I diagnosed almost 2 years ago. And here you can clearly see that the choroidal architecture is very different than what we reported. These patients are usually asymptomatic. They have no problem. They have some fluid, but they are mostly asymptomatic with a range of 20, 30. And I don't think that our ICF falls into SMAC category. This is a very distinct lesion, which has a stellate shape, and our cases did not have stellate on the on-faz, as you saw. So just to clarify that, ICF is not SMAC and ICF is not CNV scar, which we see typically. We published this last year in HAO. Definitely, there are a lot of questions. We don't have histology, so we have only questions. We want to understand that, whether the CNV developed within the choroid or some vasculature change happened which did not breach through the RP. These patients had PDT, so was it caused by PDT? We don't know. We do have fluence PDT, so I don't agree that PDT would cause this. We still don't have clue that how these ICF lesions are going to change, and what treatment response, what is the impact of treatment response on ICF, and should we be following them up closely? There are a lot of questions. We still don't have any answers. I would love to hear everybody's thought. Thank you so much for your attention.
Thank you, Dr. J, for a very interesting observation and a very nice talk. We'll have the discussion at the end of both the talks. I'd like to next invite Dr. Dhanashri Ratra, Senior Consultant at Sankara Nethralaya, very prolific researcher and surgeon, to give a talk on assessing vitreomacular.
I have lost the sound actually, but I will share the screen. Is my screen visible?
Yes, ma'am. You can make it full screen. Yeah.
Yes, ma'am, it's visible.
Yeah, sure. Okay, so first of all, thank you very much for this opportunity to talk here, Rajiv. I really appreciate, and it has been a wonderful session listening to all these interesting talks before me. So we come to the last talk of this today's program. And after listening to all this retinal fibrosis and choroidal fibrosis, we come to another tissue, which is the vitreous. And I'm going to talk to you about vitreomacular adhesion, an innocuous kind of a problem, but nonetheless important. So particularly, I'm going to talk about assessing vitreomacular adhesion in diabetic macular edema and what are the implications. No financial disclosures. So with the advent of OCT, we have been able to image and analyze the vitreoretinal interface like never before. We can see it in great details, and we can note all the vitreomacular interface anomalies that can be there. So you can have vitreomacular adhesion, vitreomacular traction, or epiretinal membrane. And among this, I'm going to focus on the vitreomacular adhesion. So apart from being an important anatomical landmark, the vitreomacular interface is also important physiologically, as it helps in transport of nutrients by diffusion, and also the numerous pharmacological agents that we inject into the vitreous space nowadays. They find a way through this vitreoretinal interface into the retina and the subretinal space. So I would say it's an important zone to learn and to know about. So let us look at the physiological changes that occur in this zone first. And we know that with age there is a synchisis and syneresis of the vitreous, and there appears a premacular bursa, that is an liquefied vitreous, which causes an equilucent space in front of the macula, and this is termed as stage 0 of the physiological posterior vitreous detachment. In stage 1, you have a perifoveal detachment, which progresses to stage 2, where you have perimacular detachment, which progresses to a perifoveal detachment. And in stage 3, you have a detachment from the macular area, but the premacular bursa is still intact. And in stage 3b, the premacular bursa is also disrupted, and you have a complete vitreous, posterior vitreous detachment. However, in vitreomacular adhesion, you have the attachment of the vitreous still to the macula. This is primarily an OCT-based diagnosis, and for the diagnosis, the following the criteria have to be met. So there is partial vitreous detachment in the perifoveal area, but persistent vitreous attachment is seen with the macula about in 3 millimeters of radius. There is an acute angle between the posterior hyaloid and the inner retinal surface, and importantly, there is absence of any change in the foveal contour or the retinal morphology. And this was further divided based on the size by the International Vitreomacular Traction Study Group. So based on size, it is divided into focal, where the vitreomacular adhesion is less than 1500 micron, or broad, where it is more than 1500 micron. It could also be isolated entity, or it could be a concurrent entity where it can be associated with either with DME or AMD. So today's my talk, I'm going to focus on vitreomacular adhesion in DME and what are its implications. So particularly, specifically, I'm going to talk on the vitreomacular adhesion and other OCT biomarkers. How does the VMA affect DME? What is the treatment response in presence of VMA? The penetration of anti-VEGF in VMA, and can the VMA worsen with anti-VEGF injections? Is it part of the fibrosis that occurs in diabetic retinopathy? And finally, the VMA versus VMT. So let us say VMA, as I said, it is primarily an OCT-based diagnosis. So naturally, our curiosity is how does it correlate with the other OCT biomarkers? So you have a number of biomarkers which predict the structural as well as the functional improvement in DME. And so we did a study specifically to look at the association of OCT biomarkers and visual impairment in patients with DME with associated VMA. We had three groups: the focal VMA, broad VMA, and the controls with no VMA. And we had about 100 eyes in each group. We used an AI-based grading platform to analyze and grade the OCT biomarkers. And we looked at the OCT biomarkers which are related to vision improvement, such as drill, the cyst location, presence of bridging lines, and external limiting membrane. And also the OCT biomarkers which predict the treatment response, such as hard exudate, neurosensory detachment, hyperreflective foci, and high reflective wall figure. And you can look at this distribution of the biomarkers and the visual impairment. And you can see that in all the three groups, the biomarkers were almost more or less similar. But the visual impairment, they were correlated significantly with visual impairment only in the VMA group. So not so much in the focal VMA, but definitely in the broad VMA. Almost all the biomarkers were associated with significantly with visual impairment. So we concluded from the study that the distribution of biomarkers was similar across all three groups. However, the visual impairment was primarily linked to the VMA group and particularly the broad VMA group. And in eyes with VMA, the biomarkers were more extensive and severe, and they correlated with poorer visual outcomes. So possibly the VMA can serve as an additional biomarker for visual prognosis. So how does the VMA affect DME? The vitreomacular, it has been seen that about 7 to 16% of eyes with DME can have various vitreomacular interface anomalies, and among them, VMA is generally thought to not contribute much to the retinal thickening. However, in our study, which I just mentioned, we saw that both the central retinal thickness and the central subfield thickness values were higher among the broad VMA group as opposed to the other two groups, that is the focal VMA and controls. And it is assumed that there is a stagnation of the VEGF and there is upregulation of VEGF and vascular hyperpermeability, which may lead to this increased thickness in presence of VMA. So how is the treatment response in the presence of VMA, whether it is, differs and whether it is, affected, the treatment response is affected by the presence of VMA? You will be surprised to know that actually the treatment response depends on the underlying pathology, and various studies have shown that in retinal vein occlusion, basically there is no change, and particularly a study by Singh et al., they did not identify any association between vitreoretinal interface status and the treatment outcome with anti-VEGF agent for macular edema due to retinal vein occlusion. Whereas in AMD, there are several studies which have shown that there is a worse visual outcome in presence of VMA, and also there can be more need for more intravitreal injections if there is a VMA present. However, in DME, there is actually a good outcome has been noted, and they have seen that DME patients with VMA have a greater potential for improvement and in visual outcome with anti-VEGF therapy. Particularly, the READ-3 study and several other researchers have evaluated the effect of VMA on treatment outcomes, and they also looked at the rate of PVD with monthly injections of ranibizumab. And what was seen that the patients with VMA do benefit with treatment with anti-VEGF, and the focal VMA eyes which subsequently develop PVD actually have the best outcomes, and about 1/3 of eyes with VMA will develop PVD in the course of treatment. So the presence of VMA should not preclude patients with DME from receiving anti-VEGF therapy. So is there any change in the anti-VEGF penetration if the patient has VMA? So there are no particular studies which have measured the penetration of anti-VEGF molecules in VMA, but indirectly several researchers have studied the treatment response in VMA as I just mentioned, and they have all shown that in the groups of vitreomacular interface anomalies, except for VMT, they found no statistical significance of outcome in anti-VEGF action, and it suggests that the anti-VEGF penetration is still effective even in the presence of vitreomacular interface anomalies, particularly vitreomacular adhesion. So can this VMA worsen with anti-VEGF, which is a natural, a question which will come to our mind. So let us look at that. So there are several studies, particularly by Veloso et al. They have shown that focal VMA, actually nearly about 70% of patients who have focal VMA, they develop VMA release with treatment with anti-VEGF. And in broad VMA, about 27% of patients developed release. About 66% patients remain stable, and they did not note any progression to VMT or ERM. So the VMA, instead of getting worsened, in fact improves, and there occurs release of the VMA and PVD. So these are a few cases which we have noted, and you can see the first image where there is a VMA, and after 4 injections there is a good response, and there is also release of the VMA. And in the second, the lower image, you can see that there is a VMA, and after first injection itself, although there is not much anatomical response, but the VMA has released. So the VMA, but we know that anti-VEGF can lead to alteration of the anatomical structure of the vitreous, which can potentially change the vitreoretinal interface. And a study by Chang et al., they actually looked at this risk factor for development of vitreoretinal interface anomaly. However, they excluded patients with baseline vitreoretinal anomaly. And what they found that there is a incidence of new vitreoretinal interface anomaly formation was about 6.5% per year. And most important was the poor baseline visual acuity was found to be the risk factor for development of new VMIA. But they did not find any difference in eyes with or without VMIA formation as far as the visual recovery or the macular edema lowering was concerned. So is the VMA part of the fibrosis that occurs in DR? And we listened to an excellent talks in the first session on angiofibrotic switch, and you can see that the severe PDR patients can have severe fibrosis, and taut PHF can be there, which can have a VMA type of appearance, which you can see in this OCT. And so these are the two examples which we have seen in PDR, and these are the situations where vitrectomy has been done, and after vitrectomy you can see the release of VMA and recovery of the macular edema. This is because, of course, there is a high VEGF concentration along with a high CTGF in PDR patients, and the angiofibrotic switch, which we mentioned just now, is the one which is responsible for this thickened PHF. However, it does not stop just at the VMA, but it can continue to have multiple adhesions, and we actually can have, of course, tractional retinal detachment requiring vitrectomy. And finally, we come to VMA versus VMT. So, of course, we know all well that VMT has much worse prognosis, and it is well established that VMT with anti-VEGF treatment has a very suboptimal visual gains, and vitrectomy is the choice of treatment for this VMT. So to conclude, in presence of VMA, the biomarkers, OCT biomarkers for DME appear to have greater extent and severity, and they were significantly correlated with visual impairment. It can be associated with higher central subfield thickness. However, it does not affect the treatment response, and it often leads to good outcome. With anti-VEGF treatment, the VMA does not worsen. In fact, the release can occur, leading to complete PVD. But VMA can be exacerbated with the angiofibrotic switch seen in PDR. So thank you very much for your kind attention.
Thank you, ma'am, for a wonderful talk. I would like to invite the panelists. We have Dr. George Manayat, Senior Consultant from Aravind Hospital, Coimbatore, and Professor Pradeep Venkatesh, Professor of Vitreoretinal Surgery at RP Center. We have a question in the chat box on to Dr. J. Because the inner fibrosis may be fibrin filled, and is there a role for steroids as treatment? What are your thoughts?
Good question. And I think that, the more we are learning about CSR, we are getting more convinced that it is more of an inflammatory mechanism. I have started prescribing very mild steroids or NSAID for some of my steroid patients. And we did publish fluoromethalone role in cystoid degeneration in CSCR. So I think that there is definitely an imbalance between the mineralocorticoid and glucocorticoid mechanisms. So definitely there is some a role of inflammation which needs to be controlled by steroids. Talking particularly about the inner choroidal fibrosis, I am not really sure that, whether if we start patients on steroids, we'll be able to prevent fibrosis, because that is something which unless we do histology, we may not be able to figure out. But I think that, I think probably the chronic cases where the treatment has not been very effective or delayed, those cases tend to have persistent inflammation leading to fibrosis. So I think that the more patients we treat with steroids, we will learn. At this point, I think we have very limited information.
Dr. George, your thoughts on this?
It was very interesting to hear Dr. Munna and Dr. Jay about the two types of fibrosis that has been described in CSC. In fact, it was even more interesting to see that in Jay's patients of inner choroidal fibrosis, all the patients had hyperreflective foci. Because we know that choroidal hyperreflective foci and subretinal or outer retinal hyperreflective foci are biomarkers in chronic CSC. I do not know whether inflammation, as Jay mentioned, as a pathogenesis, there has been a controversy whether it's a inflammation or is it a overwhelming choroidal vascular hyperpermeability in the setting of a choroidal venous overload kind of situation. Because we see the uveal effusion kind of picture where diffuse leakage beyond the arcade in the mid periphery also in some cases, especially when you have a steroid-induced CSC, as Dr. Muna Madam was mentioning, you have multifocal and RIP and beyond the arcade till the equator kind of leaks, mimicking like a uveal effusion where there is a diffuse leakage in the choroid. So that apart, we today we saw, I think, fibrosis in the subretinal fibrosis due to the fibrinous exudation organizing over the RP. And even we have seen cases where it goes on to develop RAP-like lesion in exudative RD in CSR, developing a retinoretinal anastomosis on ICG angiography at a later stage. So that is the first type that Dr. Muna Madam has described today. Then we have the fibrosis of a chronic CSE, CNVM causing a scar. I think we saw that in one of the patients of J, the right eye of a patient who has a breach, looks like in the RP. And then that is the most common ones we see in the setting of a cystoid degeneration as a late sequelae of CSC. And then we saw, very interestingly, Dr. Jay's report on inner choroidal fibrosis. In fact, we haven't looked deeply into that. We will try to look into all these patients because there it is, everything is sub-RP. Very interesting finding. Something almost similar to SMAC. I do not know even if the SMAC is a late sequelae at a later stage when there is no fluid at all in some of these patients as an accidental finding. But Jay seems to disagree on that. So yeah, so I think these are my thoughts. Whereas whether we don't know whether it's inflammatory or not, or it's a overwhelming choroidal vascular inflammation. But these macrophages, it is postulated that these subretinal or choroidal hyperreflective foci, they are actually macrophages from the dilated choroidal vessels and leaking into the initially into the inner choroid and then into the subretinal space. So I think we have one of these pathologies leading to fibrosis here. So I do not know what is the answer to that. Whether steroids, I don't know what is the role, because many a times it's steroid induced also.
Yeah, I'll just make a comment on SMAC.
Thank you,
I
sir.
think your
Pradeep Ganesh,
I'll just make a comment on SMAC. George sir, actually, when I saw the SMAC papers, and I also was under the same impression, but when I had a patient walking in my clinic asymptomatic, somebody said, you know, you have probably some scar in the eye, but there is no vision loss. Then I was like just surprised to see that this is truly a SMAC with 20/20 vision. Patient is asymptomatic, and we could actually see it very clearly. So if it was secondary to chronic CSC, which was my impression as well earlier, if this was secondary to chronic central serous, we would have seen much more autofluorescence changes and other things. But this was very characteristic. And if you really look into other series, you will see that SMAC actually has been reported in very young patients, asymptomatic. So my patient was, I think, 36 or somebody, yeah. So we had to just start looking more, that's all.
Yeah, I think inner choroidal fibrosis we are going to find more and send to you. I think you can make
100%.
you can make
Yeah,
a
let's
big paper out of it. We haven't not been looking into it.
Yeah, and I think that, we will learn that, whether it is actually happening at what stage of the disease, and that will really tell us when to start intervening, or, is ICF the end game that after that there is no change? So we will learn a lot. Thank you. It's always pleasure to talk to you about CSCR.
thank you. Professor Pradeep Venkatesh, do you think, like, if there is VMA, what decides whether it is going to have a normal PVD or is it going to go into a vitreomacular traction? Any your thoughts on this?
Yeah, Jay, sorry, your voice is breaking. Can you please repeat the question, Jay?
We see patients with a vitreomacular lesion. Is there any way to tell whether it will go into a normal PVD injection or will it go into a vitreomacular traction, sir?
Well, I don't think I have any means of saying that, but I'd definitely say that an adhesion would respond to anti-VEGF, but not a traction. If it's already a stage of vitreomacular traction, I would rather use steroids in that and not an anti-VEGF. And having said that, I mean, going through, and firstly, I'd like to thank Rajiv for having me here. So I'd like to put it across in a sense of at four levels. We have to see this whole process at four levels. One is at the cellular level itself. And I say at the cellular level, it's not just about the type of cells, it's about the balance and the density of the cells at each part of the retina, because most of the processes we are seeing is at the central part of the posterior retina. So what's the cellular density of the pro versus the anti cells that are there in the periphery versus the center of the retina? That's one thing that probably is having a role. The second thing, when we talk about the molecular aspect of this whole process, we are saying that the anti-VEGF treatment actually is causing worsening of the traction. I would like to defer in this situation here, because what is actually happening is we know that the anti-VEGFs are only receptor blockers, that the VEGF secretion in the background is still going on over there. So only quenching the VEGF at that point in time, and the moment the effect of the drug wears off, there is something like a VEGF storm that is there. And if that VEGF storm is not tackled at the right time, it's obviously going to lead to a worsening of the situation. Now, coming to the physiological, the third level I would like to look at is the physiological level. Physiological level would be the balance between the oncotic pressure, the hydrostatic pressure, and the interstitial tissue pressure that is there. So any imbalance that is there is also going to lead to this whole situation of whether it is going to heal or whether it's going to lead to scar formation. And finally, you have the mechanical factors, what Dr. Dhanashree very nicely demonstrated, the effect of the hyaloid itself. And hyaloid, one is the mechanical effect. The other thing is the hyalocytes itself. We must remember is concentrated in the posterior cortex as well as the pars plana region. regions where you're seeing most of the fibrosis occurring. So I think we'll have to look at it multiple levels. We can't isolate one and look at something in isolation. I think we'll not get the answer there. And as far as I think Jay's presentation goes, I would rather feel that the answer lies in looking at the evolution of these patients. I mean, he showed us the end stage of these diseases. I would rather look at the start and then look at how these lesions came about. That's how I would like to look at it. Yeah. And
yeah, thank you, sir, for your comments and valuable insights. Dr. Dhanashree, do you want to add anything? Yeah.
Yeah, no, I agree with Dr. Pradeep. See, I think it's a continuous process. I mean, like you cannot. It depends on what stage of the adhesion that you have seen the patient, and like how we mentioned about the angiofibrotic switch and all. So it depends a lot on the cellular factors and the VEGF level, the CTGF level, and all that. So if you have a very high VEGF level and a CTGF level, then there is a possibility that it will progress further to a BMT or a retinal membrane. And you do have patients who have got a taut hyaloid and all that. But in the absence of that, I don't think the BMA will progress as such. So it depends on this lot of cellular factors and the intravitreal environment, and also whether you are injecting any other molecules, etc.
Thank you, ma'am. So I think we are already overshot our time, and I'd like to wind up today's. We had very interesting sessions, and I'd like to thank all the speakers and the panelists for their very fruitful discussion. I would again remind you and invite you for tomorrow's session, which will be on again at 7 o'clock online.
Yeah. Thank you very much. Looking forward meeting you all again tomorrow.
Thank you, Rajiv.
Thank you. Good night.
Thank you. Good night, all of you.
Good night, Jay. Good night, Dhanashree. Good night, George.